Hello everyone, very warm welcome to all of you. And today we will deal with the peroneal tendon tear and the instability. I will talk about the clinical examination, the radiological finding, the treatment option, and the long-term effects. And I'll tell you how to examine this patient, how to isolate that this patient is having peroneal tendon problems, how to pinpoint these findings. Just follow the step-by-step protocol that I'm going to teach you. You will be able to master and you will not be able to miss any kind of peroneal tendon tear. Usually what happens in foot and ankle surgery, there is the tendons, the ligaments, all the structures, nerves, vessels, they're actually lying in a very close proximity to each other. The muscular area is very less in the foot and ankle. So it is a very close constrained spaces. So any kind of a swelling, any kind of abnormality, if it is lying there for a long period of time, it will affect the ligament, it will affect the tendon, it will affect the nerves. So definitely it will create an impact. So whenever you see a swelling in the foot and ankle area, just examine it thoroughly. And today I'll teach you about the how to examine peroneal tendon tear and the instability. So let's start. The one thing, the location of the peroneal tendon are on the lateral aspect of the ankle, clear. Second thing, there are two tendons, longus and the brevis. Accessory muscle are also there, but in the rare cases, quartus or quintans, whatever you say. We have to focus on the longus and the brevis. In case of acute cases, like somebody twisted his ankle, it can also affect the peroneus longus or the brevis. How it affects? It can create a tear in those tendons. But most of the time, what it affects, most of the time it affects the ligament, the lateral stabilizer. But right now we are talking about the tendons, longus and brevis. So if there is any kind of injury to the longus and brevis, there will be pain, and that pain will be located on the lateral aspect of the ankle. Now when the patient comes to you, whether it is a tear, whether it is a tendinopathy, tenosynovitis, or it is a subluxation of the tendon, I will tell you what is subluxation. Whatever it is, all the problems will be located on the outer aspect of your ankle or the lateral aspect of your ankle. To be specific, posterolateral aspect of the fibula, not on the dead lateral aspect of the fibula. And to be more specific, the pain will be in the subfibular area. It will not be anterior to the fibula, it will not be anterior inferior to the tip of fibula, it will be posterior inferior or posterolaterally and the inferior to the fibula. That is the precise location. So you have to ask your patient, you have to ask him to pinpoint what is the location of the pain. He will, if he is pointing in the subfibular region, now you are dealing with the what, peroneus. Second thing, so you are dealing with the peroneus longus problem. Now you have to identify it is a subluxation, or it is a tendinopathy, or it is a tear. Now ask the patient, brief the history. Ask him, did you hear any sound of pop? Or sometimes the patient himself will tell you, okay, I heard a sound of pop. So that means pop sound. These tendons are actually very strong. Okay, the pop sound here is not related to the tear; it is related to the subluxation. What happens is your peroneus longus and brevis tendon, they are enclosed in a common sheath. They do have a separate sheath, but they are enclosed in a common sheath. So they both together subluxate. From where? They subluxate from the retromalleolar groove. Lateral malleolus, if you look at the anatomy of the lateral malleolus, there is a groove located behind the behind the lateral malleolus. This groove is made for the this is groove is basically the home for this penis longus and brevis, and it prevents the subluxation. On the top of that, there is one more thing. superior peroneal retinaculum SPR. Whenever this ligament this whenever this retinaculum get ruptured, there occurs subluxation of this peroneus longus and the brevis. Now in this case of subluxation, popping will be there, and and the patient sometimes show you, because he is doing it since a long time. He is actually sensing there is something is coming out and going back, coming out and going back. When he does the specific movement, he will show you those movement also, and he will tell you, this, look at this is coming out, this is coming anteriorly, okay, coming out of the groove, coming out anteriorly. So that is the specific thing about the subluxation of the peroneus longus and brevis. There are two retinaculum, one is SPR, one is IPR. This SPR is attached to the fibula as well as it attached to the peroneal tubercle. There are four types of SPR rupture. Okay, out of these four types, fourth one is little different, because in the fourth one, the rupture actually occur at the calcaneal site. Peroneal tubercle, it is located on the lateral aspect of the calcaneum, so the rupture occur from the calcaneum side. Otherwise, in the grade 1, there is a SPR separation. It is not rupture. It is separated from the fibular end little bit. Second thing, it separate along with the fibrocartilaginous tissue. In the third grade, there is a cortical avulsion, and that we see on the X-ray as a flex sign. There is a cortical avulsion, and the last one is the rupture is from the calcaneal end. That means from the peroneal tubercle end. So this is about the SPR. That's the peroneal tendon subluxation, peroneal tendon instability. It is also known as. Now, what to do in such case? First of all, you need to identify. You did identify. You pinpoint. You examine. You look for the flex sign. There is no flex sign. Now, what will you do? You look for the MRI. Now, why you need to look for the MRI? Why you need to order MRI in such cases? Because this continuous subluxation from the retromalleolar groove. This subluxation will lead to damage to the peroneus longus as well as brevis in the form of a longitudinal tear, and these tears are the cause of the insufficiency of the peroneus longus work, because of which, when in long-term scenario, the people who ignore this long-term scenario, what will happen? They will present to you in the form of a deformity. They can present to you because the peroneus longus and brevis, they are not working. What is the function of these? We'll talk about the brevis and the longus. The brevis works for the eversion, that's the primary function, and the longus, it has a 60% eversion power of that brevis, plus it is the main, its main function is the plantar flexion of the foot and the plantar flexion of the first ray, its primary function. So whenever these longitudinal tear are there are a lot of plantar flexure are there, but everter, the brevis is the strong one and longus is assisting him. If there is a tear in the bow, there will be insufficiency. So what will happen? There will be recurrent twisting of the ankle whenever he walks on the uneven ground. What will happen on that uneven ground? Or whenever you walk on the uneven ground, there is a subtalar joint motion which allows the balancing of your foot as well as the ankle, and that stabilizes your whole body. If this part of your bone, if this part of your and if this subtalar joint motion is not stabilized because of this insufficiency of the peroneus longus and the brevis, what will happen? There will be twisting, there will be fall, recurrent fall, too many time twisting, and the patient will have the ligamentous issue as well as, and he will complain of what? Giving away of the ankle and the apprehension, I'll fall. These are the typical findings the patient will describe. So sometimes because of the ATFL CFL tear, you get a peroneus longus and the brevis degeneration or the tear or the tendinopathy. Sometimes because of isolated this SPR, superficial superior peroneal retinaculum rupture pathology, because of the subluxation, you will get the chronic instability and the ATFL and CFL damage. So these two things, they works like if one get damaged, it will lead to damage to the other part. So this is a circle. This is a circle basically. They work in a circle. So How we deal with this SPR, this damage of the SPR. Now, the first thing, those people who take the graft, who take peroneus longus as a graft, in case of ACL reconstruction, there is just one message to these people: do repair the SPR, but don't do it in a tight manner. Use 330 Vicryl or the monocle, whatever you are using, but use it 30, and do not over tight it, because this area which is available for the longus and brevis or in the foot and ankle, whenever you are taking sutures, you don't need to over tight those, because it is a closed constrained spaces already. These spaces are very, this space in the foot and ankle are already too much tight. They have very less space, and if with the suture you are closing it too tightly, what will happen? You're compromising the space, and ultimately you are hampering their function and damaging those structure. So whenever you are taking the sutures, use the 30, do not over tight it, just keep it like this. And in the post-op rehab, please, what do one thing, give a slab or start mobilizing them, okay? And in case of SPR, after 7 days, do the mobilization of the of the ankle, not in the initial 7. Let the sheet, let the sheath heal, okay? Let the sheath heal.